now that we've established a philosophy of assessment, the next thing we're going to look at is a series of assessments that we can use to determine an athlete's mobility, proprioception, and capacity. What we mean by these three terms is range of motion at various joints, the ability to control those joints in space with balance-based tasks and landing-based tasks, and then finally capacity, which is the ability of tissues to withstand repeated loading. So I've put these three different categories together because often they fit well together within a single assessment session, and then the running-based assessments can sit alongside that in another presentation that will follow on from this one. But firstly, I wanted to recap on what we looked at from the previous presentation, which was the overall kind of purpose and philosophy of assessment to begin with. So I just wanted to recap that first of all it needs to inform the impact of the program, so whether we're actually progressing and the athlete's actually getting better. Secondly, that it determines capability in relation to the demand. So now we've got a clear idea of what hockey requires of us, the main injury risks. This really acts as an injury prevention screening process to see what are the limiting factors and whether there are sort of major red flags that would pop up that would put an athlete at risk. And then what is the physical limitation to performance? So in this section, we'll be looking at, are there any tests that we do that highlight the fact there are limitations to an athlete's individual performance based on these assessments. So I just wanted to recap on that because it's important to kind of reiterate some of these key points. So in effect, this section is going to look at which assessments are aligned with the sporting demands based around key injury profile, points that we've established to ensure that an athlete is fully prepared for their sport and that there aren't any red flags for injury risk that may limit their ability to perform. So we're going to begin with looking at mobility assessments. There are 4 ones we're going to look at. And before I start talking about these, the protocols I've included in a separate document for you to use, along with a video showing you how to do it. So have a little look and check that out as well. So you've got that kind of guideline to follow. So we're not going to be talking in huge amounts of depth about the protocol because that's included in that document, but just as a high level overview of why you would use it, roughly how you would do it, some of the normative data associated with it, and a bit of a rationale for why you would want to use these tests as well. As I say, the final bit of this section is going to be you sort of evaluating which of these ones you currently use, if any, which ones you might think you'd be good to start using, and in the end, which ones you're going to start to implement in your own program. So in this mobility assessment sort of part, we have overhead squats, a knee to wall assessment, an active straight leg raise, and a seated thoracic rotation. So an overhead squat, first of all, we're going to use the rationale for this is that hockey involves large ranges of motion. If you look at the picture of the guy here doing an overhead squat, you're in really deep positions of hip flexion, ankle flexion, whilst trying to control through the trunk with arms elevated overhead. So we're really challenging whole body mobility in this sense, and particularly in flexion. So imagine hockey players typically having to go into these really low positions in tackling, shooting, competing for the ball. If an athlete is struggling to get themselves into these deep positions of flexion here under control, without the chaotic environment of hockey, it's unlikely they'd be able to do that effectively on the pitch. So it assesses global movement competency and control, by which we mean multiple joints in synergy, being able to control the whole body through motion without any compensation. And very simply, scored out of 3. So this would be a 3 because there's no compensations here. 2 would be there are some compensations. 1 would be you can't complete it at all, and 0 would be pain whilst performing it, which would then need to be referred to someone medical, because if you've got, say, for example, hip impingement pain, then that's the kind of thing which a physio needs to be taking a look at. Now, when we do the test, you don't use a barbell. You actually use a wooden dowel. A hockey stick can work perfectly well, but typically we want to be able to get our arms wide enough that we can get our arms into these sorts of positions here. So 45-degree angles at the arms. So we wouldn't be using a barbell, but it highlights the point of what the position should look like. So no compensations here would be that the hip is below the knee in relation to the parallel. There's an upright torso. The bar remains above the middle of the head here, and there's no lateral sway of the trunk, no forward movement of the bar, and there's not a limitation in terms of the depth being able to be achieved, either with the ankles coming up or the athlete having to kind of raise their hips slightly and almost hinge forward to achieve positions. So that would be a 3. 2 would be any number of those things, and a 1 would be they can't complete it, just can't do the movement without sort of falling over or losing control. We've then got, within the mobility section, the knee-to-wall test, and this is this test right here. The primary rationale here is that the ankle joint is required to undergo large ranges of motion during lunging, tackling, and shooting. So as you can imagine, in these sorts of positions here, when you're in low down positions, if I just flick back quickly to this position, you can see sort of during shooting and passing, the ankle is expected to go through quite large ranges of motion at high velocity. And so we need to be able to assess these things in isolation. So this is a reliable assessment of ankle dorsiflexion, as it provides consistent, reliable results. So it's been sort of proven in research that it's a nice, reliable test, and you get really good assessor reliability, which means that if a number of people were to perform the same test on the same athlete, the results would be very closely matched, which means that there's not an unreliable test. So it's a valid and reliable assessment of something which is relevant to positions that you experience in hockey. Scores are in centimetres. Sometimes it can be done in degrees, but for simplicity we can do it in centimetres, and the score is taken from the edge here of the wall that you're actually using out to the front of the toe here. And 10 to 15 centimetres from the wall to the front toe, there would be a good ballpark, and less than 10 would obviously be a sort of target for improvement there. Obviously, we can also look at asymmetry, so if one side is particularly good and one side is particularly bad, then there could be compensation happening up the chain, so that's another important one. You get a number of attempts at this, so you can kind of continuously move your foot back. Effectively, you start with your foot on the wall and begin to edge that back, pushing your knee against the wall, until a point at which you're not able to keep your heel flat on the ground or rotate at the hip in order to achieve these sorts of positions. So a really good one for assessing isolated ankle range of motion, which is super important in hockey. Active straight leg raise, again, we're going to go through large ranges of motion at the hip joint, and lower back pain can be related to limited ranges through the posterior hip, hamstring, and that kind of thing as well. Imagine when we're going down into these sort of forward flex positions when we're going in for tackles, if there's any sort of limitation in posterior hip range of motion, being able to get that hip here into flexion, then oftentimes it puts stress through that lumbar spine, which we definitely don't want. So this assesses mobility of the posterior hip and hamstrings. Lying on your back, keeping the opposite leg straight here, we have a vertical line halfway between the iliac crest at the top of the hip here, the bony part of the pelvis, to the knee, in a vertical line, and the athlete keeping the opposite leg straight brings it up as high as they can. So this would be a 3, okay, because as you can see, they can achieve range beyond this 90-degree line. A 2 would be between 45 and 90, so halfway here in this sort of range. A 1 would be less than 45 degrees. That would be very, very limited in terms of hip range. And then again, 0 would be pain. So a useful one for determining kind of how much range of motion you got through that posterior hip, which is obviously related here to lower back pain and can be a useful sort of indicator of potential contributing factors in that sense. So it requires very little equipment, just needs a wooden pole or some sort of, you can even use a hockey stick again as like a vertical line, and it can be done anytime you like as a good measure, but just ensuring that legs are kept straight. And then finally, in the terms of mobility assessments, we have the seated thoracic rotation. Hockey obviously requires large thoracic ranges of motion in the transverse plane, so rotationally. Whenever we're passing, shooting, we're always going through rotation to be able to create those sorts of shapes. And this is a useful indicator of active range at the thoracic spine and in isolation. So the athlete sits on a bench or a box like this with knees at 90 degrees and feet on the floor, and with a bar across the back here, the athlete rotates as far around as they can until they can't reach any further. Again, this is scored out of 3, so a 3 would be more than 90 degrees of range. So in other words, with the bar would be obviously rotated to the edge of this bar here would be facing forwards and the back of the bar would be facing over here, so in basically a straight parallel line. 75 to 90 degrees, which is roughly the sort of position that this athlete's in here, would be a 2, and then less than 75 would be a 1. So that would be quite limited in terms of thoracic rotation. If there is limitations in thoracic range, often what happens is you start to get compensations in terms of lumbar issues. It's more stress placed on the lumbar spine if you can't rotate through the thoracic, and you often get things like shoulder-related pathologies as well. So it's important to determine how much range of motion an athlete can achieve. And again, going back to what we've said before about determining capability in relation to demand, there's a lot of demand placed on the thoracic spine for range. If the thoracic spine has not got range, then there's going to be potential issues for the athlete later down the line. And in the next section, then we're going to look at proprioception and balance assessment. So I've had a good idea now of some good assessments we can use to assess general mobility. Now, other assessments obviously can be super useful, and if you went to a physiotherapist, for example, there'd be much more in-depth analysis that can be done. But for the sake of simplicity and for practicality, these are the ones that can be done by anyone, anywhere to a degree with very limited equipment. So the two here are a single leg balance and a single leg hop. Now, proprioception and balance, we mean here being able to control the joint's position in space and have a very good awareness of what the joints are doing. So these two are a useful assessment of these two things here. Firstly, a single leg balance. Primarily here, the sort of rationale is that half of all, and particularly female, this is also a male, it's highly prevalent, ankle injuries and lower limb injuries in general account for a third of total injuries experienced in hockey. And this assessment determines basic proprioception of the ankle joint and the joint position sense of the lower limb. So it's a very simple test that you can do here just as a general marker of proprioception, which is eyes closed on a single leg with hands across the shoulders. And essentially you're trying to measure how long you can hold that position for without losing balance. And you allow one compensation here. So if you were to lose balance a little bit, but corrected it quite quickly, that would be okay. On a second time, you would stop there. And objective evidence and research has highlighted that around over 15 seconds is considered good. That's sort of like a normative data. And if you can achieve 60 seconds, then that would be regarded as really, really good. And obviously this is something which can be trained. The first time you do it, it's likely that within a few seconds you might topple over, but with a few efforts you can build up to much better joint position sense. The benefit of doing this is that obviously you're going to have much better control of that lower limb and better proprioceptive capabilities at the foot and ankle, which is one of the most prevalent injuries in the sport. And you can attack something like an ankle sprain, injury prevention sort of program from multiple angles. Doesn't just need to be strength training, also needs to be mobility, and also proprioceptive work as well is vital for this. So balancing and hopping is key. The other test then is a single leg hop. So this is starting on a single leg and hopping onto the same leg on landing. Basic rationale here is that hockey requires unilateral control and deceleration during tasks such as decelerating and changing direction. And this is a really simple test of single leg control and stability and is reliable. It's been found to be a reliable measure. What we're looking to do here is hop from one leg onto the same leg, and the measure is taken from in centimetres, the front of the lead leg, from the toe, and then from the back of the heel upon landing. So front of the toe to back of the heel upon landing. And ideally we want a target of less than 10% asymmetry. So if we had a metre on one leg and then 1.5 metres on the other, clearly that would be a massive difference, and that would suggest that one limb is significantly weaker than the other, which is probably going to highlight either a previous injury or some major sort of issue there. Now, that would be an extreme one, and typically you'd probably see that in something like an ACL post-surgery score. So that would be a kind of extreme result, but typically under 10% is regarded as sort of the gold standard to aim for. And the smaller the better. Normative values, the primary ones taken here are from sort of female and male collegiate athletes, so it does differ for different demographics. This is by no means exhaustive, and there are ranges for different demographics. But if we just take this as a general ballpark to kind of aim for around 1.9 meters or 192 centimeters in male collegiate athletes, 1.5 meters, 149 centimeters in female collegiate athletes are regarded as normative values for those sorts of demographics. And you can obviously remove some distance there for younger athletes and older athletes as well. But that gives you a rough idea of what good would be considered as. But more importantly than the absolute number that you achieve is the relative difference between the two limbs. And that's more important for you individually and for athletes in general. So try to focus more on that. So in combination, these two tests give us a good amount of information around what the ankle is capable of doing, if there are any asymmetries between the two, what the quality of the landing looks like. And it's good to kind of record these sorts of things so you can see exactly how an athlete lands when they're performing the task. And that gives us lots of helpful information. Again, going back to this idea of capability versus demand, there's loads of demand placed at the ankle joint, and it's a high-risk area. So if an athlete's got poor proprioception, a 20% asymmetry between the two limbs, and we'll obviously look at this in a second, but let's say poor calf scores as well, the risk at the ankle is heightened because they're further away from the demand that is being likely to be placed on the ankle joint. So the job is to increase those scores to get closer to these normative values. And the final bit in this video then is around tissue capacity assessments, and I'll be just explaining in just a second what we mean by tissue capacity, and also going into this in more depth in the strength training section. But as an assessment overview, these are 5 tests that you can do, again requiring very little equipment, that determine the capacity of key injury areas, or key parts of the body, that provides us with useful information around asymmetry, capacity, and ultimately injury prevention as a whole as well, or potentially where parts of the body might be at risk. So when we say tissue capacity, we mean tissue capacity is the ability of tissue to withstand repeated loading. So this is sort of synonymous with muscular endurance. And for example, if a athlete's able to perform 25 calf raises, 30 calf raises, which is considered a good sort of ballpark, then the muscles that are responsible for plantar flexing the ankle, so the gastrocnemius and the soleus, would be regarded as having a good capacity to withstand that loading, whereas an athlete who could only do 12 calf raises is really severely limited in that sense. And so we can try to obviously increase the number of repetitions that they're capable of achieving there. So it's super, super important. Equally, research in elite Dutch hockey's highlighted that 63% of injuries are overuse. So the majority of injuries actually are overuse and not traumatic, so not kind of sudden or acute injuries. And this kind of gives us information that would suggest that if that is the case, then increasing the capacity of tissues to withstand these sorts of loads over time is going to help to offset the risk of those injuries. So if we think about things like, because of the amount of volumes you're experiencing, things like hip and groin injuries, lower back issues, ankle injuries, a lot of these things are related to the fact that over time, an athlete becomes fatigued and then their capacity is lower than the demand being placed on the tissue. So our job is to increase the capability. So then we've got these 5 tests. So a single leg squat is the first one. And this is to a box. So a single leg squat to a box down to 90 degrees. So the height of the box needs to be appropriate. That at the bottom here, the knee is at 90 degrees. Hockey players obviously require the ability to decelerate unilaterally under control, and quadricep strength is a key preventative measure for ACL injury as well. So during ACL rehab, trying to increase the kind of capacity in a single leg squat and a calf and quad girth, that kind of thing is super, super important. So it's got an injury prevention outcome as well. And this is a really simple means of assessing capacity of the knee extensors. So very simply, athletes squat down on a single leg to the box, and then without bouncing back off the box again, they control back up under a good tempo, so sort of like 1 second down, 1 second up type tempo for as many reps as they can achieve to failure. And a target would be 25 repetitions on a single leg and again within 10% asymmetry. So 25 and 24 would be good, whereas 25 and 40 would be a huge difference. So that one leg would need to be obviously brought up to match the other one. A couple of key things with this one, the main sort of issues that might be experienced in terms of the reason why people might fail would be bouncing off the box, or losing balance. So if the athlete loses balance a little bit, then that's a kind of what we call a deviation. You're allowed one deviation in total. So when the second one comes around, that would be the end of the test. Okay, so you're trying to achieve 25 repetitions as a good target there. Second one is a single leg bridge, and hamstring injuries are super prevalent in hockey. We know this from lots and lots of research, and it allows programs to be modified because once you know that the capacity of the hamstring is in place, then you can start to focus on other areas, which is a useful thing. Like, for example, in this hierarchical model that I sort of propose, once tissue capacity markers have been met, you can begin to focus more on things like maximal speed and possibly maximal strength, that kind of thing. But until the basic ability to tolerate lots of volume is met, it's kind of hard to focus on other areas because the risk is still there. Very simply, again, using the same box that you would use for a single leg squat, you bridge up on a single leg so that your knee is up at 90 degrees at the top. You perform this to a metronome, so you need to use the very simple Google metronome, which if you just type in metronome onto Google, it will come up automatically, and set it to 60 beats per minute, and the tempo should be up for 1 second and down for 1 second. And Freckleton et al. Established the following norms: less than 20 was poor, 25 was average, and over 30 was good. So you'll find over time that actually a lot of these tests typically sit in the ballpark of around 25 repetitions as being a good sort of marker, although obviously that was regarded as average. 25 to 30 repetitions for a bridge, single leg squat and calf is generally a good ballpark for hockey players. The next one then is a single leg calf raise. Again, ankle sprains are a very common injury in hockey. So it's typically around 30% of injuries, or up to 30% of injuries, are related to the ankle. This test assesses strength and capacity of the calf and soleus, which is important for ankle injury prevention for a number of reasons. Again, we've said before, but these muscles are responsible for attenuating the forces experienced at the ankle joint during things like unplanned decelerations, change of direction, and sprinting. And so if we can increase the capacity of the calf, we can put athlete in a better position to withstand that sort of repeated loading. And again, normative data from 2017 would suggest that based on age ranges here, 20 to 29-year-olds would be, for men, 37 reps, and for women, 30. For 30 to 39-year-olds, it was 32 and 27. And for 40 to 49-year-olds, 28 and 24 was about right. Having said that, even at the GB hockey standard, 35 for men's and women's hockey would be regarded as excellent, and 30 would be, again, considered pretty good for pathway hockey as well. So again, if you're in and around 30 repetition mark, that is a good sort of measure to aim for. Above 25 ideally, above 30 even better, and 35 would be excellent. And then that 37 for 20 to 29-year-old males. And then the last two tests here, we've got Copenhagen Holds. The hip and groin injuries are really prevalent in hockey. Primarily this is owing to the kind of split stance positions and high speed running involved. So when you're finding yourself, again, these tackling positions, shooting positions, the adductor gets placed under loads of strain because you're in deep positions of hip flexion in this split stance position. So this is a test to assess the capacity of the adductor muscle group to withstand hip abduction. So in other words, by holding this position like so, the adductor on the inside of the leg is preventing the hip from abducting inwards. And this is important because it provides insights into hip and groin injury risks. So a good sort of target for this would be 60 to 90 seconds per side, and again, a less than 10% asymmetry would be a good sort of ballpark once more. very simply, keeping this position here, a straight line through the leg, trunk, and out through the head here. That's the exact position we're trying to hit. And if you were to have one deviation, initially that's okay, and then the second one would be the end of the test. So again, you can check out the protocols to see exactly how to do that one in more detail. But in effect, a score of around 60 to 90 seconds per side would be a good sort of ballpark. Finally, then we've got some trunk muscle capacity assessments. So lower back injuries are a huge factor in hockey, and up to 53% of players have reported this previously. And one of the main reasons for this is, again, those low positions, the repetitive nature of it, the sort of semi-rotated positions that athletes have to get into, and so the spine's placed under a great deal of stress. These capacity assessments basically determine the capacity of the muscles that support the trunk, and these muscles help to contribute to spinal stiffening, which ultimately reduces shear forces on the lower back, and also helps to reduce the need for lumbar muscle work, which is a positive thing. It means that the muscles of the lumbar spine are having to do less work, which means there's less stress on the area, which means that hopefully we're going to get a reduction in lower back pain and other sort of issues there. In the supine trunk hold, you can use a GHD like this, or if you've just got a bench or a box, you just need someone to help to hold the legs down. The top of the pelvis here should be in line with the top of the edge of the step here, and you're going to hold this start position in this kind of dish shape here for as long as you can. Common issues with this one that would cause the test to be stopped would be bouncing. So in other words, the athlete starts to lose the position and can't regain, or they start to curl up to make their life easier, or they simply can't hold the position and have to stop. On the lateral trunk hold, similar sort of principles really. Same side position here, nice straight line through the body. Again, bouncing, rotating, the head position being lost, or any sort of pain would all be reasons to stop the test. And the ballpark of 90 to 120 seconds is about right here. And both typically can be capped at around 2 minutes. You're not going to get a huge amount more benefit of going beyond a sort of 2 minute mark. For the lateral trunk holds here, less than 10% asymmetry is ideal. So again, if one side's a lot stronger than the other, that may potentially be a kind of mark and a sort of flag there to look to improve. So there's been a ton of information there, and I wanted to make sure that you had the ability to go through all those tests with me, and just to make sure that had some clarity on things like how they're done, the rationale for them, how it relates to the philosophy that we spoke about, how it relates to the demands in hockey. And then all of these references here are for you to have a little read through if you want to, that kind of follow on and obviously provide all the information and justification for everything I've included in this section. So in summary, the reason why we assess again is to determine an athlete's capability in relation to sporting demands. We've known what the sporting demands are now because we've covered that in quite a lot of detail in terms of the injury and running profile of the sport. The main injuries are ankle, hip, hamstring, and lower back. And a lot of these assessments here are designed to assess the underlying sort of physical qualities that help to prevent those injuries from occurring. So I hope that's been useful. Again, make sure you check out the protocols document, and that will break it down into a bit more detail of how you actually do the assessments. There's a video attached to it as well. And hopefully that's been useful in terms of giving you a high-level overview of all the different tests and how to implement them. So looking forward to the next section, and we'll be looking at the next section of running conditioning and which assessments are most useful for hockey.